Okay. Yeah, I'm live right now on YouTube.
Okay.
Study, which basically talks.
Thank you, Muskan. So hello and welcome to MedNews Week conference, where our goal is to bring you the most cutting-edge information from medical's global leaders. I'm Shrivika Kannan, and I will be your host today. Before we begin, I want to first acknowledge the great team that helps us make these events a reality. Welcome to MedNews Week conference, where our goal is to bring you the most. Sorry for that. So our founders are two internationally recognized researchers, Dr. Jan Leifman and Chandler Park. Our chairs include Dr. Park and Dr. Leifman. Our associate directors include Madhuri Balasubramanian, Muskan Joshi, and Gayatri Menon. Our associate directors include Alexandra Vandekaft, William Wilkerson, and Ahmed Aziz. Our educational committee includes Sean, Shubha, Harshal, Shri, Soumya, Rabab, Imad, and me. We also would like to thank our partners, Vimedi and the National Society of High School Scholars, and also i3 Health. i3 Health is a CME, NCPD, and CPE accredited organization with the mission of enhancing the proficiency of the multidisciplinary team by providing evidence-based activities that address unmet educational needs for the healthcare team. Oncology Data Advisor is i3's new website that delivers up-to-date, clinically relevant content, interviews, and contemporary form key opinion leaders in oncology. The moderator for today's event is Muskan. Now, to introduce our keynote speaker, Dr. Tania Jain. Dr. Jain is an internationally recognized leader, speaker, and researcher in hematology-oncology. She is the recipient of She's a recipient of multinational and international awards, including the H.G. Hundrey Award for Scholarly Excellence. She has held numerous national and international leadership positions, including the Chair Committee of Education of the American Society of Transplantation and Cellular Therapy. She is a passionate and a dedicated mentor who has trained students at all stages of the training. She's also published more than 50 original research articles. With that, it is my pleasure to welcome Dr. Tania Jain. The floor is yours, Doctor.
Thank you. Thank you very much for such a generous introduction. As I was telling you both earlier, I'm in awe of all the work that you're doing, and I'm absolutely delighted to be participating in your effort. So our goal today is to talk a little bit about CAR T-cell therapy, kind of recognizing the diverse audience. We've tried to keep it at a varying level of understanding. So hopefully we'll engage a variety of the listeners here. As already said, I'm at Hopkins. These are my disclosures. So a few things that we'll talk about today. I do love a good history lecture. I don't know if I'll be good at it or not, but I will try to connect the dots between the past and the present with regards to CAR T. We'll talk a little bit about the practical aspects related to safety and toxicity. We'll talk about how the future may look and some of the things that we're doing. And lastly, we'll talk very briefly about how to build this CAR T program or CAR T garage or CAR garage as some people refer to it. So let's start with actually introducing a term, immune effector cell. So what an immune effector cell is that it's an immune cell, obviously, which is differentiated enough and capable of effecting, of modulating, of causing an immune response which is targeted to specific cells in the world of oncology against cancer cells, but obviously this is now expanding beyond oncology. So the oncological reference may become a historical perspective for the next talk that we give. So there's different types of immune effector cells. CAR T cells, probably the most prominent ones because they are the most advanced and commercially available and whatnot. But then there are activated NK cells, there are T cell receptor therapy, there's virus-specific T cells, there's tumor infiltrating cells, and so forth that have been used potentially to treat various conditions, including oncological and non-oncological. So let's start with the historical perspective. So this is where we are today, right? We revel as a hematology oncology physician. We play with these products and have a variety of these available for diverse conditions. But we also need to recognize that the decades worth of work that went into bringing it to the stage where it is. And the first version of immunotherapy or cancer immunotherapy was actually nowhere close to CAR T cells. It was something called Cooley's toxin, which was used in the late 1800s by Dr. Cooley to treat bone cancer using a strep bacterial injection to modulate the immune system to get activated. And then there were tales from Steven Rosenberg's lab. There were the first generation CARs. We'll look at that in a second. There were, prostate and breast directed CAR T cells, which had their own limitations. And until we stumbled upon the success of second generation CAR T cells in murine models and then subsequently in humans, that is what pivoted the journey into this glory or the current phase of CAR T cells. Obviously, the CD19 CAR T cell in pediatric ALL with the success of treatment was a major breakthrough, resulting in recognition across the globe, followed by lymphomas, and then obviously we're exploring third and fourth generation immune effector cells. But this is, as you see, 1891 through 2015. So not even decades, probably over a century worth of investigations and step work leading up to where we are today. This is a short piece that I wrote for Ash News Daily a couple of years ago. But Dr. William Bradley Cooley, who's now known as the father of cancer immunotherapy, they first started using strep and inducing erysipelas in 1891 to treat a tonsillar mass, and subsequently treated other patients with osteosarcoma and so forth with some success. And obviously it was recognized as an alleged remedy at that time. We love skepticism when anyone brings anything new to the world. So this was considered as an alleged remedy, and obviously here we are today. So what initially met with a lot of skepticism was a 3-patient report for patients with sarcoma. Patients used to get a severe attack of erysipelas, but also followed by an extensive necrosis of the tumor. And there were patients who had remission lasting years using this. And then coming to what our current topic or current version is, this is a basic structure of a CAR, chimeric antigen receptor. The word chimera comes from an even earlier historical perspective. It comes from the Greek mythology, where it refers to a fire-breathing monster, a fire-breathing hybrid creature, where the forebody is made of a lion's, the hindbody is made of a serpent, and the mid-body is made of a goat. And similarly, a CAR is made of 3 different entities which are combined or unified to make one entity. So there is the antigen binding domain, which is derived from an antibody, so that there is no MHC restriction. And then there is the internal or the intracellular activation domain, which is at least CD3 zeta. And now we also have co-stimulatory domains, but the purpose of the activation domain is to activate the T cell when it meets its target cell. So this was a basic structure, first generation CAR T cell. And while this was transformative science, these first generation CAR T cells were not really effective because they were not as cytotoxic. So the T cell activation was not very high, and they couldn't persist or expand for a long time. So the proliferation was low. And so this is the first generation thing. And this led to the second generation CAR T cells, which developed in the late 1990s, where in addition to the extracellular antigen binding domain and the CD3 zeta activation domain, there was a co-stimulatory domain that was added, which is the red circle, to activate the T cells a step further or a notch further. And that improved the cytotoxicity, that improved the proliferation and the persistence of CAR T cells, resulting in more meaningful responses that we see today. And then there is third and fourth generation CAR T cells that are being explored using two co-stimulatory domains or using an inducible domain to modify the activation signaling of the CAR T cell. So this is the first reported patient treated CLL patient at UPenn using CTLO-19 in CLL using the 4-1BB co-stimulatory domain. As you can see, a lot of lymph nodes in the therapy timeframe, and those improved 3 months after treatment. You can see that even in the coronal section of the CT scan, that this lymph node in the axillary area, both of these disappear after about 3 months of the treatment. And out of the patients that they treated, there were about 3 at that time who had a longer or a durable progression-free survival. And as we now know from a recent report last year in Nature, that 2 of these patients have shown persistence of their CTLO-19 CAR T cells more than 10 years after their initial treatment. So clearly there's persistence, there's some responses. The proportion of responses may not be as high, but this was one of the first reports of CAR T cells from Dr. David Porter's group. Then came the CD19/28 zeta CAR T cells from MSK. There were about 5 patients treated in the first series for ALL, and all of them had a very good remission. 4 of them went on to get an allo transplant. I show you bone marrow images from 2 of these patients, and you can see at day -4 and day -1, the left panel full of disease. And if you look at the day 59 and the day 50 images, there is restoration of hematopoiesis with clearance of the bone marrow disease upon treatment with the CD19/28 zeta CAR T cells. Obviously, the most pivotal point was this report in 2013, which was a 2-patient report from UPenn, of whom 1 actually had a lasting response. But this was a New England Journal paper for CD19 CAR T cells in pediatric ALL. The picture on the right is Emily Whitehead. She's known to many and everyone, who is now more than 10 years cancer-free from her initial treatment. And it didn't always look that way. When she was initially given CAR T cells, she had high fevers and was not looking good, was admitted to the hospital, to the intensive care unit, intubated, pressors and whatnot. The other patient did not have a very lasting response to begin with. And I often make this comment that if Emily Whitehead had not had a lasting response and survived the CAR T cells, and be the poster child as she has been, we probably would not have been as acquainted with the field of CAR T cells as we are today. But this was probably the most transformative moment in the context of CAR T cells. So as we talk about fevers in Emily Whitehead after her CAR T cells, let's get into the safety issue of this. As you all now know, the fevers that she had right after the infusion of CAR T cells, we now know they are a version or they're a manifestation of the hyperinflammatory response that happens after CAR T cells, which we call as cytokine release syndrome. And cytokine release syndrome itself is a manifestation of a slew of interleukins and inflammatory markers that get released into the blood, resulting in capillary leak, tachycardia, your entire sepsis scenario, hypertension, organ failure, and whatnot, which we label as cytokine release syndrome. And some of the cytokines that we know are well implicated in this is IL-6, and you can see in the panels below that people who have, or patients who had a higher grade CRS had higher levels of IL-6. The right two show ICU versus non-ICU admission instead of the severity, but both show that patients who had an ICU admission had a higher level of IL-6 and higher levels of CRP. So clearly an inflammatory mediated response, and IL-6 has a special meaning because that is what we use to target treating CRS in these patients. And as you can see here, the temperatures in this particular patient rose to above 40 degrees Celsius, which is very, very high. And the IL-6 levels, as pointed in the arrow in panel B, were very high as well. That's the black curve. And they use IL-6 receptor antagonist called tocilizumab to treat this, following which you see the temperatures die out, the temperatures sort of fade away, or the temperatures get better, and the serum cytokine levels get better as well, and stay that way. Clinically, the patient herself was extubated. She was able to come off of pressors within 48 hours of introducing tocilizumab, and improved back to health. So since then, the approval of CAR T cells has included approval of tocilizumab for treatment of CRS, as we all know. These are the two initial lymphoma studies, ZUMA-1 and Juliet, using axi-cel and tisa-cel respectively, and obviously now we have liso-cel or Breyanzi approved as well. And you can see CRS occurred in a majority of patients. It was high grade in a substantial fraction. I would point out that the grade 3, grade 4 in Juliet looks higher than what we expect, but that's only because they used a different grading system, which sort of escalates people to grade 3 if they have any hypertension, whereas the ZUMA-1 used a different grading scale. So, it's not the same grading scale that's used here. And frequent use of tocilizumab, not an infrequent use of vasopressors. So clearly some high-risk CRS was happening in these trials. Which has led people to think, what is the right time frame for tocilizumab? Should you wait for fevers to continue? Should you wait for hypertension to occur? Should you wait for hypoxia to occur, which are signs of organ failure or impending organ failure? And when people have given tocilizumab early, meaning before hypertension, before hypoxia, the rates of severe CRS have been low, without an increase in the rates of ICANS and without an implication towards hematopoietic recovery. So question always comes down to whether early tocilizumab is reasonable. And I think the field is moving more and more towards the answer yes to that. Especially because we know that IL-6 is not required for the expansion of the CAR T cells itself. It's mostly causing the toxicity. Also, because the field is moving more and more towards outpatient CAR T cells, and hence early intervention has been an area of interest in the field. I'm sure all of you have this at your centers using some sort of an algorithm, some sort of a guidance document to treat CAR T cells. We obviously use tocilizumab. We use it early, especially with the Yescarta and the Tecartus products, and corticosteroids or anakinra or siltuximab if patients are refractory, or if the CRS is refractory, I'm sorry. Then immune effector cell-associated neurotoxicity syndrome, or ICANS, which is relatively unique to CAR T cell. Obviously, we've also seen this with BiTE, so any sort of T cell activation has caused some of the neurotoxicity syndrome picture. And the patients can present with a plethora of symptoms, sometimes as subtle as taking time to answer questions, sometimes as subtle as feeling more tired or fatigued or having a headache, or as subtle as having tremors, which are not limiting function. So all those things are important to recognize, and obviously more severe situations can present with confusion, disorientation, delirium, sleep disturbances, or difficult to wake up, or more somnolence. Seizures have been seen, weakness has been seen, papilledema on exam has been seen, and imaging will usually reflect cerebral edema. Classic picture for handwriting test, which most centers tend to do at least every day for the first couple of weeks. The important thing here to note is that it improves. So you see the first sentence the patient writes, and then the second sentence patient writes when they are in the phase of neurotoxicity, and then the third sentence they write when they recover. And that's important to recognize for the house staff, for the patient, for their family, that this will improve, and it does. It's temporary. It needs to be managed appropriately, but it is not going to last forever. The mechanism for this is probably less clear than what we know about CRS, but possibly involves passive diffusion of the cytokines that we talked about into the brain, possible trafficking of the T cells into the CNS, and we know that happens because we've seen responses in patients with CNS disease, and some EEG findings in some patients have shown evidence of cortical irritation, which is probably another etiology for this. So those are some of the mechanisms that have been proposed in terms of resulting from increased vascular permeability and damage of the blood-brain barrier, and pericyte damage as a result, causing ICANS. This is something that we do at Hopkins, which is fairly standard. We check their I scores and ICANS grading every day. Patients get Keppra or levetiracetam for 30 days as prophylaxis. And we use standard AST/CT grading systems, which I would encourage everyone to use so that there's more standardized reporting and practice. This is our ICANS treatment sheet, which uses dexamethasone, which uses anakinra if no response to dexamethasone, and so forth. A lot of times I will say that it is time that improves these patients. So as long as we're taking all the appropriate supportive care we're making all supportive care interventions, those things are important to recognize. The question is, can we predict these? And there's a lot of work going on in this area. There's several people who've published a lot of important pieces related to that. I'll show a couple of things that we have done. So E6 is something that's used in the context of transplant, and includes creatinine, LDH, and platelets in that equation. What the MSK group did is they modified the E6 score to include CRP instead of creatinine, and that score was validated in predicting, or at least investigated in predicting CRS and neurotoxicity. And patients who ended up developing severe CRS had higher modified E6 score at earlier stages, meaning at like lymphodepletion or day -1. And similarly for ICANS, while it was not as well correlative, there were signs that patients who had a higher E6 score at day 1 and day 3 ended up developing ICANS compared to patients who had low scores. Intestinal microbiome has been correlated with CAR-T outcomes as well. This was work that I participated in with MSK in collaboration with UPenn, and exposure to antibiotics in the month prior to CAR-T cells, especially the PIM antibiotics, the Piptazo, Imipenem, and Meropenem, which is known to alter the gut flora. Patients with lymphoma who were treated with CD28 zeta CAR-T cells, as well as the 4-1BB CAR-T cells, both of them had a lower overall survival following CAR-T cells, and appeared to have higher rates of neurotoxicity in both of these cohorts. The fecal diversity, as studied by 16S RNA sequencing, was low in patients with patients who were undergoing treatment with CAR-T cells, and low alpha diversity was associated with lower probability of CR at day 100, which is the blue bars. Another thing that we're recognizing more and more is hematopoietic recovery or delayed hematopoietic recovery, called cartopenia or IEC-related hematopoietic toxicity, basically referring to cytopenias after CAR T cells. And we and others have shown that counts drop very significantly after CAR T cells. The nadir is, for example, close to 0 for ANC, in the single digits for platelets, and transfusion requirements needed in the context of hemoglobin. And this is true for all products. The severity is at its peak is high, as you can see, grade 4 for most patients. The recovery takes time. The recovery takes 2 to 3 months, which is why, again, a lot of patients and a lot of, management is required to make sure that these the treatments are done safely. Recovery in this case, in this graph, is defined as hemoglobin more than 8, platelets more than 50, ANC more than 1,000. And as you can see, about half of them require 2 to 3 months to get to the point of hematopoietic recovery. Normalization obviously takes longer, and can take up to 12 months or 9 to 12 months. So it's important to recognize that even if the counts are not coming back immediately, they will come back, and you need to make sure that we're supporting the patients well enough with transfusions, infection prevention, and things like that. We wrote a recent paper on a recent How I Treat series, and this is a figure from that. It's a nice sort of pocket guide to think about the reasons for early cytopenias, which is in the first 30 days, prolonged cytopenias in 30 to 90 days, and late cytopenias occurring beyond 3 months from CAR T cells, because the implications and the reasons for each of these time points can be different. The earlier cytopenias are almost exclusively attributed to the lymphodepletion chemotherapy, but some of the toxicities of CAR T cells, like IECHS, and I'll come to that acronym in a second, needs to be recognized. Infections need to be recognized all the way through. When you're getting towards the late cytopenias, you need to start thinking about marrow involvement of disease or immune-mediated hematopoietic suppression. And those are things that are areas of active investigations as to how to manage those, how to treat those. People have reported the use of stem cell boost, and that's the bottom right corner, with some success. If stem cells are available, obviously there is a cost that goes with it. There is a resource utilization that goes with it. And there is some data on the use of TPO receptor agonists as well, which has had some success in trilineage hematopoietic recovery, not just platelet recovery as well. What we've shown, and others have shown too, is that the extent of immune toxicities that occur right after infusion of CAR T cells do seem to correlate with hematopoietic recovery. Grade 3 to 4 CRS and ICANS, patients who experience grade 3 to 4 CRS or ICANS have a lower likelihood of recovering their counts at day 30. A similar result was shown from a study from Seattle, from Jordan Gauthier's group, showing similar things. CAR hematotox is a score or a potentially predictive score that has come from Kai Rojeski's group from Germany, and they have really taken control of this field, showing that this scoring system done at baseline, where you get points for low platelets, low ANC, hemoglobin, CRP, and ferritin, and that score can predict hematotoxicity or extent of cytopenias occurring after CAR T cells. Recovery of neutropenia can happen 3 different ways. Patients can just have a recovery at about day 14. Some patients will have a recovery, but then have a second round of neutropenia, and some patients could potentially have a very prolonged aplasia where the counts remain low for several weeks following CAR T cells. And we've all absolutely had those patients with a very hypocellular marrow, even if you do a bone marrow biopsy without disease involvement. So I promised I'll introduce the term IECHS, and what that means is immune effector cell-associated HLH-like syndrome, and that has been reported in rare scenarios as well. A very severe inflammatory reaction, potentially fatal, so important to recognize. So if you see this patient, from a series of patients that we reported, the patient had CRS at about days 4 to 6, followed by improvement upon treatment, and then had a recurrence of fevers at about 3.5 weeks, with a second rise in ferritin, which went up to as high as 100,000. Other parameters of HLH at this time, including triglycerides, fibrinogen, liver enzymes, all sort of flew in that direction. Interestingly, IL-6 and CRP drop. So while you see a rise of IL-6 and CRP in the context of CRS, you will not necessarily see that in the context of IECHS. And then again, you can commonly see cytopenias when the HLH-like syndrome happens, similar to what you would see in HLH otherwise. What's important to note here is the timing. So there has been a lot of discussion in the field about if IECHS is different from CRS, and the answer, I think, is yes. But it's important to recognize that you could see some of those things while you're dealing with the original version of CRS. And the CRS that, or what you think may be IECHS that happens overlapping with the CRS is not truly IECHS. What is IECHS is the latter two scenarios on this picture, where patients have CRS, which resolves, and then a few days later, CRS-like symptoms begin again. And if you measure some of their DIC and liver panels and triglycerides and such, you will see the changes suggestive of IECHS. Similarly, in the fourth panel, it may take about 3 weeks for this recurrence to happen, and it may not happen right away. But every single patient reported to date with IECHS has had prior CRS. But it's important to recognize that the CRS recovers before the IECHS develops. So how are we stepping into the future? There is, as you know, tons of research going on in this area. There's several novel agents being explored, several methodologies to make the CAR T cells better, several strategies to develop predictive biomarkers and predictive models to predict toxicity and response. And it's hard to put all of that together in one slideshow, but I'll show a couple of things that we're trying to do. We're looking at the immune metabolic profiles of CAR T cells, which has been shown to determine the severity of COVID, which was, if you remember, the inflammation from COVID was also a T cell response. So what we're trying to do is to determine if the metabolic markers can predict persistence of CAR T cells, resulting in potentially responses, and also toxicity following CAR T cells. And this is a paradigm of our sample collection that we're following, creating a biobank of these longitudinal samples in collaboration with Dr. Erica Pierce's lab and Dr. Michael Stanczak, who are major collaborators on this project at Hopkins. Can we develop CAR T cells faster? So obviously, remember, right now it takes about 6 weeks from decision to wane, and about 4 weeks from wane to wane. Can we do this faster? There are options off the shelf that are under investigation. Challenge has been so far persistence of those. What I would like to introduce is the concept of in vivo CAR T cells, which has been published in the context of cardiac fibrosis, and it's also something that is being investigated for oncological conditions. Can we make toxicities better? Can we make lives of people better after they get CAR T cells? And there's a lot of effort going on in that direction as well. We have a small proposal to use ruxolitinib for IECHS management that we're exploring, but a lot of other work is going on looking at the timing of tocilizumab, IL-1 inhibition. There were 2 recent publications using anakinra as prophylaxis for neurotoxicity with slightly variable results, but certainly something that is of interest. Linzilumab, which is a GM-CSF antibody, has drawn some traction in this context as well to use as a preventative measure for improving toxicity and potentially even CAR T expansion or efficacy following infusion. How do we build a CAR T program? I've heard people talk about this, and as new CAR T programs are building up, I'll just quickly show spend a couple of minutes on that, just out of interest for the most part, but happy to elaborate later in a different conversation. But this is what setting up a CAR-T program looks like. It's not a single step. There are several steps that go on even after a product approval happens from the FDA. These are financial approval team, apheresis team, shipping people, cell therapy labs, clinical teams, education resource is some of the few things that are some of the many things that are needed to build a functional and effective and a successful CAR-T program. And those are, as you're thinking of building a program from scratch, those will be things that you will need to think about or put these pieces together. With that, I'm going to end, I hope I was helpful in introducing you to the revolution of the CAR-T cells that is happening right now. I am happy to take questions now, or if you want to email me later, my Twitter handle, or I guess now Z handle, whatever, is down at the bottom on the left, and my email is down at the bottom on the left. If there's anything that I can help with, please feel free to reach out. Thank you very much.
Thank you so much, Dr. Jain, for that amazing presentation. And thank you so much to everyone for coming to our discussion with global leaders. I am Muskan Joshi, and we are super excited to be speaking with Dr. Tania Jain today, who is the director of the Effector Cells IC Cell Therapy and the assistant professor at Johns Hopkins University School of Medicine, Sidney Kimmel Comprehensive Cancer Center at Johns Hopkins Hospital, Division of Hematological Malignancies and Bone Marrow Transplantation. We have received a lot of questions, and we'll do our very best to get through all of them for the time that we have with you. So for the first question, I am going to be passing the mic back to Shrivika.
Thank you, Muskan. Once again, thank you, Doctor, for such a wonderful keynote. It was truly informative. So my question for you is, in respect to developing countries, what difficulties would be there to implement the latest advancements in CAR-T cell therapy?
Yeah, so I'm glad this comes up, because this is something that I tried to touch on in my last slide, and I'm glad we're getting a chance to elaborate on this. So, as you know, the price tag that comes with the commercial CAR-T products is way high. If insurance payers are not agreeable to that, which the systems are not as developed in everywhere to have insurance payers pay for these things, it's just not possible to afford. So the cost of manufacturing has to go down, and there are ways to do that. Not everything has to be centrally manufactured. There is a very flourishing concept of point of care manufacturing, which cuts down your cost of manufacturing by at least a log, and that is probably one of the few ways that to cut down the cost, and that is one of the ways that countries, at least like in India, I know, and some countries in Africa are trying to develop CAR-T cells using the point of care manufacturing. The piece around the overall structure kind of speaks to the fact that you cannot just do this in your garage, right? Which is probably good and bad. I don't want to be doing this in my garage. But at the same time, it also means that you need the level of functionality as a tertiary care center, meaning that you have an ICU service, you have a neurology service, you have an ID service, amongst others, whose help you will need to take a patient through CAR-T cells successfully. So that sort of infrastructure, the number of centers that may have that level of infrastructure may vary depending upon where you go. And that's important to recognize as well, that we may be starting at a smaller scale, but certainly something that has the ability to expand by being creative and by doing different things.
Thank you so much, Doctor. Over to you, Muskan.
Thank you so much, Dr. Jain, for that wonderful answer. For sure, overcoming the socioeconomic barrier and ensuring that there is proper accessibility and availability of the latest cancer therapeutics is the key to having global health equity. So for the very next question, I'll be passing over the mic to Gayatri.
Thank you so much, Dr. Jain, for that very insightful presentation. I really learned a lot. So my question is, other than c-KIT mutations, I was wondering what other gene mutations do you think can be potentially explored to make CAR T cell more effective against solid tumors?
Yeah, so the challenge, or I guess opportunity, that exists to go beyond having a surface marker that is unique to the cancer cell and not seen in any normal or needed or indispensable human cell is an interesting challenge, right? And CAR T cells, while they're great and have all these advantages that we talked about, they may not, they certainly do not have the strength of doing this if the marker is not present on the surface, or the mutated the mutation is not, or the mutated sort of receptor is not present on the surface. And perhaps CAR T cells are not the way to go for something like this. Perhaps something that has more intracellular activation is probably the way to go for this, which is sort of why you will see, hopefully in the coming months, a tumor infiltrating lymphocyte product, a TIL product by a company called Iovance. It's called Lefulicil, being considered, or at least it's under consideration at the FDA for treatment of metastatic melanoma. So to use T cells from the cancer or the tumor microenvironment, engineering them to become more activated, more specific, and more potent to kill cancer cells, and infusing them back to the patient are some things that are being considered. The other alternative is something like a TCR, or a T cell receptor strategy, which sort of which is MHC restricted compared to CAR T cells, which are not MHC restricted. But using that to target things that may not necessarily be present on the surface. So, not everything has to use CAR T cells. Not everything can and has to use a surface marker. And quite honestly, surface markers that are present only on the cancer cell and only on dispensable normal tissue, normal cells, are going to be very few, and CD19 is probably one of the unique ones. You've seen a decent bit of toxicity with BCMA products, probably because it is present beyond the plasma cells, right? There's some expression in the basal ganglia, as we have now seen, resulting in some movement disorders in patients long term. So not all targets will be as perfect as CD19 is, or not all tumors will have targets that are as perfect as CD19. And hence, we will need to explore strategies to go beyond surface expression in terms of being able to target tumor cells.
Thank you so much, Doctor. While it's great to learn about CAR T cells, I guess it's really important to explore its limitations as well. So thank you so much for that. Over to you, Muskan.
Thank you, Dr. Jain, for that wonderful answer. That was truly really interesting to hear. So for the next question, I'll be passing the mic to Harshita.
Thank you, Muskan. Thank you, Dr. Jain, for the wonderful lecture. The question that I have for you is that does CAR T cell therapy interact with other treatments for cancer like chemotherapy and radiation? If so, how do they complement or interact with each other?
Yeah, so that's an interesting question. So a few sort of obvious ways is that, well, obviously, you know that we use lymphodepletion chemotherapy prior to CAR T cells to allow for expansion of CAR T cells and sort of create those immune sinks so that the CAR T cells can expand. using a chemotherapeutic strategy after CAR T cells, obviously will be sort of detrimental to the efficacy of CAR T cells. Radiation is an interesting concept to explore. People have tried radiation in the context of bridging therapy with some success in CAR T cells. Whether the abscopal effect that we see with chemoimmunotherapeutic agents like immune checkpoints will be seen with CAR T cells. I'm not aware of data so far that has necessarily shown that, but it's an interesting concept if antigens are being released and hence more of those are available for the CAR T cells to act on. What people have shown previously is the use of BiTEs or bispecific T cell engagers with CAR T cells, and there is some exploration of that in the context of both lymphoma and myeloma at this point, to use a T cell engager on top of a CAR T cell to bring the CAR T cell closer to the tumor cell potentially for subsequent apoptosis. But those are some of the ways that I'm not sure if chemotherapy necessarily beyond the lymphodepletion chemotherapy has a lot to complement, but I think strategies such as radiation and immune check and T cell engagers, and actually even immune checkpoints, right? People have explored using CTLA-4 and PD-L1 inhibitors in combination with the CAR T cells. Not very encouraging results thus far, but I think that is also a concept in evolution.
Thank you, Doctor. Over to you, Muskan.
Thank you, Dr. Jain. Again, that was a wonderful, wonderful answer and something really important to consider. So for the next question, I will be asking a question. So my question kind of goes along a different tangent. So I really wanted to know, have there been any so I have been really interested in epigenetics lately. So I wanted to know, have there been any epigenetic changes or any epigenetic modifications that have been identified that have perhaps rendered the CAR T cell therapy ineffective or may have increased its efficacy, in a way to say it? So like, what are the various epigenetic modifications that you may have observed during this therapy in like different people, because it completely varies from person to person? So I would just love to hear your insight on it. Thank you.
So I'm not sure I understand the question. I wonder if you're referring to perhaps the TET2 modifications that have been reported in some CAR T products, which led to a more robust expansion and
Yes.
efficacy. But those are anecdotal reports. There is some interest in exploring what things like clonal hematopoiesis may result in, both of the hematopoietic system and perhaps even in the unmodified T cells, host unmodified T cells, or even gene modified T cells after the CAR has been introduced. Those are some of the areas that are interesting, but right now we don't have a lot of data there. There is one case report of introduction of mutations via the CAR T cell resulting in T cell ALL, but I don't think that's kind of what you're asking. So this will be something that will be that will come to light over time, and perhaps already is. There are at least a couple of publications in the context of clonal hematopoiesis sort of suggesting that there may be a role in terms of CAR T efficacy and even the toxicity or extent of toxicity.
Thank you so much, Dr. Jain. That was definitely so this is something I've been really interested in. It was really amazing hearing it from you. And I will definitely be doing more of my research into this. And definitely you've opened up a new arena for all of us to think over here, especially related to CAR T cell therapy. So thank you so much for that. So for the very next question, I'll be passing over the mic to Harshal.
Yeah, thank you, Muskan. Thank you, Doctor, for the insightful session. So my question is, considering the complexity of the hematological malignancies, How do you see the role of multidisciplinary teams in optimizing patient outcome with CAR T cell therapies?
Doctor, you're on mute.
Dr.
Yes. So in terms of post-CAR T management, sorry, can you clarify the question? Are you asking in terms of post-CAR T management?
Yeah, I am asking that in regards of multidisciplinary team approach in the like management of like patient after CAR T cell
Yes,
therapy.
post-CAR T. Okay. Yeah. So, as I was alluding to earlier, that it's certainly a team that you will need to take care of these patients. And these, as you know, are going beyond oncology, and the same discussions are happening that you need an IEC or an immune effector cell toxicity expert. You need an ICU team, you need a neurology team, you need an infectious disease team. At the very least, these services to be working alongside as you take care of these patients. People have also reported cardiac toxicity and renal toxicity and so forth, which may be additional services that may come handy in certain situations. So overall, it certainly is a multidisciplinary care model that is required for these patients, similar to what people usually have for transplant. And that is why sort of the need for more like a tertiary care model for something like this.
Thank you, Dr. Jain. So for the next question, I'll be passing the mic to Dr. Shah.
Thank you, Muskan. Thank you, Dr. Jain, for your wonderful presentation. My question from you is, by considering the clinical trial involving the genetic modifying organism, I was wondering that what is your personal insight around the safety and efficacy as well as the protocol biosafety?
Oh, safety and efficacy of what? Sorry, you got cut off.
About the efficacy, safety, and protocol biosafety specifically.
I'm sorry, I think I may have missed a part of the question. Safety, efficacy, biosafety of CAR T cells?
Of the protocols, right? Because we know that there is a use of the, GMOs through the CAR T cell event. And I was just wondering, knowing your consideration or insight around the protocol biosafety, any guidelines or any updates through the guidelines and regulations, and what might be your personal insight?
I'm not sure how well I'm going to answer this, but I'll try because I'm not sure I understand the question. But the biosafety piece that you're referring to, I think, refers to the virus handling in the context of manufacturing, and that is the piece that is that requires the specialized manufacturing units, or GMP as we call them, with the level of standards that can be used for clinical manufacturing and clinical or manufacturing of products that go into patients. And all of them will have specific protocols that will be followed. Like every clinical trial that comes across will have certain nuances to it that will be elucidated in their protocol, or even standard of care product comes with all of those instructions. As regards to the product handling, again, that happens in the cell therapy lab, at most places, which again are well equipped, or should be well equipped in the context of handling cellular products, freeze, thaw, storage, temperature regulation, and so forth. Similar to what we end up doing for transplant, autologous and allogeneic transplant products for transplants.
Yeah, thank you so much for your response.
Thank you, Dr. Jain, for that wonderful answer. So for the next question, I'll be passing the mic over to Imad.
Hi, doctor. So my question for you is, what's the potential for the CAR T-cell therapy to be used as treatment for viral infections or even other non-cancerous diseases, or maybe even solid tumors?
So, as I was alluding to earlier, the use of immune effector cells is certainly exploding beyond heme malignancies and beyond oncology. Viruses have been an area of interest for a while. As I'm sure you've heard of the viral specific T cell product that is sort of multi-targeting, that targets adeno, BK, HHV6, and perhaps CMV and so forth. And there have been successes with that. Alovir is a company that has a few of these products and has shown some promising early results. We have a clinical trial for COVID-specific T cells, which are donor-derived in the context of a bone marrow transplant. And we've, again, early results, few patients, but very interestingly, we've seen patients after transplant, their family member got COVID, but the patient remained COVID negative after infusion of the COVID-specific T cells. So I think, again, I don't want to speak too much with regards to smaller number of patients, and there's only so much to make out of it, but that is an area that will certainly see a lot of, we are in fact already seeing a lot of development in, and obviously they will offer a very competitive option against the toxic drugs that exist right now, which we usually end up using for treating things like CMV infection and so forth after transplant. As far as other conditions, as you must have seen the recent couple of publications in the context of use of CD19 CAR T cells in rheumatological conditions, that area is on the verge of explosion, or maybe post-explosion at this point. There are several products, several companies exploring CD19-directed immune effector cell strategies for treating rheumatological conditions. And it probably makes all the more sense, right? Because in your lupus patient, if you kill the B cells, they're not going to keep coming back and cause relapse, which is a problem in oncology. In oncology, however, you could stomp on the cancer cells for the moment, but they will come back. So the role of something like our T cells or immune effector cells, T cells of activated T cells of some version, will absolutely have a role, or at least their role is being investigated at very enthusiastic levels in the context of autoimmune conditions and lupus and other rheumatological conditions.
Thank you so much, Doc.
Thank you, Dr. Jain. That was a wonderful answer, and definitely I gained a lot of insight on this. So for the next question, I'll be passing over the mic to Lexi.
Thank you so much, Dr. Jain, for this wonderful talk. My question is, what are you most looking forward to in the future of hematology-oncology?
In general, or with regards to T cells? Cure for all?
Yeah, or both.
What we would want ideally is cure for all. More realistically, I think establishing these therapies as more accessible, so that the science is not just science for a handful of people. The science is something that everybody can access and benefit from, and that will require things like cost reduction, making them safer so that they don't require a multi specialty tertiary care center for implementation, they can be done more easily and offered to more people at more centers. So safety measures, cost measures, efficacy measures, so that the responses that we often see are short-lived, or sometimes see are short-lived, they can be converted into more durable responses and potentially cures after treatment. And I think these three are not unrealistic. These are possible, need a lot of work, and hopefully we will, in the next decade or so, see a lot of advancements in that space, which will take us forward towards those goals.
Thank you so much.
Thank you again, Dr. Jain. So for the very last question for today, I will be passing the mic over to Rabab.
Thank you so much, Muskan. Thank you so much, Doctor, for your amazing presentation and sharing an insight on CAR T-cell therapy. So my question to you was, for our more junior attendees just getting into research and medicine, what inspired you to pursue the field of oncology, and how has this choice impacted your life? Has it been everything that you had initially anticipated?
So the fact that I get to interact with such bright minds as yourself, I have been absolutely enthralled this evening with all that you do. I feel like I did something right. So the fact that you get to interact with the budding future, which is so bright and so smart and so active, is certainly something that should drive people into doing oncology or medicine or science. For me, it was not a particular incident or something. It was sort of a natural course of sorts. I did my med school in India. We really didn't know what cancer treatment was beyond surgical interventions or radiation, I guess. And there was clearly a need to go beyond that, which is probably in some ways led to my interest in oncology to some extent, because I hadn't seen any of that. So I wanted to explore what I haven't seen. And beyond that, I think heme malignancies again was a bit of a natural course, sort of pathway development, probably partly related to the mentors that I had over the course of my training that led to this. CAR T or immune effector cells or CAR Ts have been an interesting field that we have seen develop as we were trainees or as we were entering the field. So that has, for that reason, has generated a lot of enthusiasm and interest to be able to participate in this growth, to be able to watch it happen, and be able to speak about it to people, to your generation of physicians, is particularly fruitful.
Thank you so much, Dr. Jain, for that wonderful answer. As an IMG myself, who is very keenly interested in oncology, you are truly an inspiration. And I'm sure all of us here as your attendees and as the MedNews Week team are beyond privileged to have you here on our platform. So although I would love to go on and listen more to you, and we have tons of more questions that we would love to go through with you, it is now time for us to wrap up our session. So thank you again, Dr. Tania Jain, our wonderful speaker for today, and for an amazing session. We appreciate you giving your time and effort to create and give such an amazing presentation and answering all our wonderful questions.
Wonderful. The honor has been
And
mine.
thank you so much.
As I've mentioned earlier, it's been an honor to work with you all. I wish you all the best and good luck with all of your endeavors. And if there's anything I can do to help, please feel free to reach out.
Thank you so much, Dr. Jain. Those words truly mean a lot to all of us listening to you right now. So thank you so much again to Dr. Jain, and thank you so much to all our wonderful attendees for such amazing questions and such an amazing participation. Please continue to follow MedNews Week on all of our platforms and be sure to catch the replay. Don't miss out